विवेक
बिजु
विवेक
तिमी त्यही लिंकबाट सजिलै आयो हैन
म त्यहीबाट आए
निरव दाइको हुँदै भएन भनेर मेसेज गर्दै थियो के भन्छ
ए त मैले लिंक हाले हैन मैले त पासवर्ड अनि त्यो हाले हो आइडी अनि पासवर्ड
सुरु तिमीले नै गर नि त
मेरो त प्रेजेन्टेसनै छ नि तिमी सुरु गर न म तिम्रो प्यानल डिस्कसनमा म हेर्दिन्छु त्यसपछि म हेर्दिन्छु नि यतिकै त टेन्सन भइरहेछ साथी निरव दाइ आउनु भयो
भर्खर आउनु भयो दाइ नमस्ते निरव दाइ दाइ
नमस्ते
ओ वासुकुला सर के हो
हेरौँ न
निरव दाइ
सुशील केही प्रब्लम
डाउन एरो गर सुशील डाउन एरो भएन भने माउसले एकचोटी त्यो स्क्रिनमा क्लिक गर अनि चल्छ क्लिक गर एकचोटी अब चल्छ अब एरोले माथि तल जाऊ न
हजुर थ्यांक यू सर I'll briefly cover the bundles, attachments, septum, vascularity, and nerve supply. And these topics may overlap with one another in a single slide or maybe in different slides sometimes. To begin with, PCL is the strongest ligament of our knee. It has attachments in femoral condyle, medial femoral condyle, and on the tibia, it is attached in a depression that is called PCL facet, slightly posterior and inferior to the intercondylar eminence. While on the medial femoral condyle, it is attached on the lateral surface of the medial femoral condyle, inferior to the medial intercondylar ridge. The length in an average is 32 to 38 millimeter, and the cross section is 13 millimeter square. The femoral attachment of PCL, this is the femoral attachment of PCL. This is twice as large as the tibial attachment. And there are two bundles, anterolateral bundle and posteromedial bundle. Functionally, they have their respective roles. And these two bundles are sort of enclosed by the meniscofemoral ligaments anteriorly and posteriorly. This is the femoral condyle. This is right knee in 90 degree of flexion. That is how it appears during surgery. This is a sketchy picture, but this is the cadaver right knee. The lateral condyle contains sulcus terminalis. This is sulcus terminalis. Here you can see here. This is the depressed portion on the inferior portion of the lateral femoral condyle. And there is another point. This is the convex point, slightly medially to the apex of the intercondylar nodes. This is called trochlear point. And after the trochlear point, the cartilage starts arching medially, and it becomes concave, and it comes to an end at a certain point, and then it starts descending downwards as a straight cartilage. This is the point where the medial arch ends. This is called medial arch point. And then there is another point called bifurcated prominence here. This is the bifurcated prominence along the medial intercondylaris. This point can be taken as the bifurcated prominence here. And if we draw a triangle out of these 3 points, then it forms a triangle. This is the attachment of AL bundle, that is anterolateral bundle. Somewhere around the center, if you pass the guide wire, then we are recreating the anterolateral bundle. That will make a tunnel for the anterolateral bundle. There are a lot of figures to remember. So many millimeters inferior to the trochlear point and so many millimeters posterior to the medial arch point. It is actually difficult to get by heart all the figures. This is just a basic idea about the attachment of the bundles. And then there is another bundle called posteromedial bundle, inferior to the anterolateral bundle and inferior to the medial intercondylar ridge, posterior aspect. And this bundle anteriorly there is attachment of the anterior meniscofemoral ligament, while posteriorly it has posterior meniscofemoral ligament. These meniscofemoral ligament they clasp the bundles of the PCL such that even if the PCL ligaments are torn, then it allows minimal displacement of the torn PCL, thereby allowing the PCL to heal. On top of that, the meniscofemoral ligament, they also provide anterior-posterior stability. So much so that when the PCL has been torn, it is recommended not to release the meniscofemoral ligament because they provide additional anterior-posterior stability. And these are the corresponding arches and corresponding points in the cadaver knee here. This is the right tibial condyle, posterior view, lateral aspect, middle aspect. And this is the PCL facet showing the attachment of the bundles. We are looking at the tibia from posterior aspect. If we take two parasagittal sections of the tibial condyles, one from medial and one from lateral, this is how it looks like. This is the posterior aspect, and this is vertically oriented here, both medial and lateral aspects. But in case of mid-sagittal section, this is slightly different. There is a posterior slope, while at a certain point, it starts sloping anteriorly. If you compare this with a glass of champagne here, this is the glass of champagne, the slope that goes anteriorly resembles with a glass of champagne. So this point is also called champagne glass drop-off, from where the slope starts going anteriorly. And this is the attachment site for capsule as well. And this is the PCL facet here, where the PCL attaches, and we make a tunnel from anterior direction such that the guide wire exits somewhere around the PCL facet. This is the capsule attachment, and there is a popliteus muscle just inferior to the champagne glass drop-off. Tibial condyle, let us have a 3D picture of the tibial condyle. There are certain important anatomical landmarks for tibial attachment of the PCL. This is the champagne glass drop-off. This is actually not transverse the way it is shown in the picture. This is actually going superiorly and laterally here. And this is the champagne glass drop-off. And slightly superiorly and anteriorly is inferiorly is the popliteus muscle, and superiorly and anteriorly is the bundle ridge. This is called bundle ridge here. Now, if you look at this champagne glass drop-off, this is the site where capsule also gets attached, and this is the popliteus muscle. So, if the capsule has been torn either during surgery or either during trauma, then popliteus muscle is visible. But if the capsule is intact, we don't want to damage the capsule, so that we want to visualize the popliteus muscle. Simply, we can feel the champagne glass drop-off with the help of a probe or saber or even radiofrequency ablator. And this bundle ridge separates the anterior medial bundle from the anterior lateral bundle from the posterior medial bundle. And there is another important landmark called shiny white fibers. These are shiny, glistening white structures, slightly inferior to the posterior horn of the medial meniscus. These are very important landmarks during surgery. And this is the anterolateral bundle and posterior medial bundle. But as shown in this picture, this is the skeletonized tibia. As shown in this picture, this may not be as clear during surgery because there are a lot of soft tissues in this posterior aspect of the knee, including the septum along the mid-sagittal section. So let us see how the septum looks like. This is the septum. This is the PCL here and capsule here, and this is the popliteal artery, slightly lateral to the mid-sagittal section here, and this structure is septum. This is actually composed of fibrous septa on the two sides with an intervening connective tissue and fat in between them. So this is called septum. This actually is bounded anteriorly by the PCL, posteriorly by the capsule, superiorly by the intercondylar, superiorly by the roof of the condyles. And it is again very interesting to note that the vascularity goes from the superior aspect of the septum And there are mechanoreceptors also are present on the superior aspect. So we don't want to damage the superior aspect of this septum to preserve the mechanoreceptors and the vascularity. But releasing the central portion of the septum, there is no harm in releasing the central portion of the septum. So this is the axial section here, and this is the pulpitular artery. Now, the pulpitular artery is very close to the septum. How do we release the septum? Basically, if we release the septum here, central and inferior portion, the pulpitular artery is going to fall back more posteriorly. Here, this is before the release of septum, and this is after release of septum. On top of that, we are going to reduce the blind spot at the meniscocapsular periphery. If we do not release the capsule, the blind spot is 21.5% with the conventional AL and AM portals. But if we add posterior medial and posterior lateral portal, the blind spot is only about 8.4%, but septum is still intact. What if the septum is divided or released? The blind spot is approximately 0%. So it's very important to understand the anatomy of PCL, anatomy of the septum for PCL reconstruction. After releasing the septum, the distance from the tibial attachment of the PCL increases from 4.4 millimeters up to 4.4 millimeters to 14.7 millimeters. This is approximately 14.7 millimeters because this is where the guide wire is going to exit. So we don't want to run the risk of injuring the pulpitular vessel. So the anatomy, of course, of the septum is, of course, very important here. Regarding the innervation and blood supply, the innervation is by the posterior articular nerve. This is the branched tibial nerve. These are the mechanoreceptors. These are more concentrated on the superior aspect of the septum and more concentrated on the femoral attachment of the PCL. So this is the idea behind the remnant preservation PCL reconstruction. And this is also the idea behind why we want to preserve the superior aspect of the septum here. Because we well know the mechanoreceptors are important for proprioception of the knee. And the blood supply is by middle genicular artery. This is middle genicular artery, and this is a branch of the pulpitular artery. The genicular artery not only supplies the septum, but also supplies the posterior cruciate ligament. So the femoral attachment and the tibial attachment of the PCL are very crucial before we reconstruct the posterior cruciate ligament. This is just the basic idea about the surgical anatomy of PCL. Thank you very much.
Thank you, Sushil. That was really very nice talk. Now, are there any questions, Vijayendra?
No, still there is no question, I think.
From seniors and from the participants within the Zoom platform, are there any questions in Sushil's talk, sir?
Vivek, I just want to add.
Okay, sir.
Hello. That was thank you, Sushil. That was a very excellent anatomy, as well as the related anatomy that we should know when undergoing any kind of surgery. PCL. It was very nicely represented and very succinctly and to the point where surgeons are interested. I just wanted to add that. I just wanted to congratulate him on his presentation.
Thank you, sir.
Okay, if there are no further questions, so
Vivek.
Yes,
Yeah, this is Amit. I think it's a very one of the. This looks a little, because Sushil is trained on transseptal approach. There are many people who are doing not transseptal approach, but through the two posteromedial approaches also.
Yes.
So there are both advantages and disadvantages of removing the septum. Sometimes these septums are too thick and it consumes a lot of time to clear the posterior aspect of the knee. Sometimes the anatomy of septum varies, right from the single septum going on and from the double septum, and its attachment into the tibia is not known where it goes. It comes from posterior capsule and from tibia where it attaches. Either it attaches into the PCL or it goes down where, up to what level it goes is also not very clear. The anatomy is not clear. But However, for last so many years, we have been practicing transseptal. And recent publication also says that transseptal has lesser chance of vascular injury compared to the other techniques. So probably if you learn how to make a posteromedial and the posterolateral approach very safely, a transseptal technique is very good technique. That is what my experience is.
Yes, sir. So if there are no further questions and comments, I would like to ask my dear friend Vijayendra Adhikary. He is going to talk about biomechanics of PCL, a very important topic for us orthopedic surgeons. Vijayendra?
Thank you, Vivek. So is my screen visible?
Yes,
And I'm visible?
yes, it's visible.
Thank you, Vivek. And first of all, I'd like to thank Arthroscopy Society of Nepal for giving me the opportunity to speak in this platform. So my previous speaker, Dr. Sushil Thapa, my good friend, have presented very well and well illustrated diagram about the anatomy of the posterior cruciate ligaments. So today I will be talking about the biomechanics of posterior cruciate ligament. So why it is important to discuss about the biomechanical function of the PCL. So as we know that the biomechanical function of the PCL and its individual bundles have great illustrated its overall function role, and it's provided the new perspectives on both non-operative and the operative treatment of PCL. So going to the introduction parts, as we all know that So going to the introduction part, we all know that the PCL is the strongest ligament in the knee, and its main function is the main stabilizer of the knee joint and serves primarily to resist excessive posterior translation of the tibia relative to the femur. As in open chain function, PCL resists posterior translation of the tibia, and in the clone chain function, PCL resists anterior translation of femur. The functional roles of the PCL are determined by the knee flexion angle and the loading conditions such as posterior translation force and rotational torque. We all know that the PCL also acts as a secondary stabilizer of the knee, preventing excessive rotation, especially between the 90 to 120 degree of knee flexion. Kennedy et al. Have a study on the kinematics analysis of PCL on the individual and collective function of the anterolateral and the posteromedial bundles, and they have reported that PCL provides restraint to internal rotation beyond 90 degree of knee flexions. And they have also mentioned that when equivalent internal and external torques are applied to both intact and the tear PCL knee, there was increased internal and external rotation to a tear knee compared to intact PCL knee. So as my previous speaker, Dr. Sushil, have said that we have got the two bundles of the PCL, that is anterolateral bundle and the posteromedial bundle. Both these bundles have their own mechanics and they function independently. With the anterolateral bundle acts primarily during flexion and the posteromedial bundles act in the knee extension. However, most recent researchers have said that the two bundles function synergetically. So in this diagram, we can see that when the knee is flexed, the anterolateral bundle is taut and the posteromedial bundle is lax. Whereas in the knee extension, we have got the posteromedial bundle is tight and the anterolateral bundle is lax. So under posterior tibial load, as the knee flexion angle is increases, forces are also increases in both the anterolateral bundle and posteromedial bundle. The secondary stabilizers like the muscles like gastrocnemius, quadriceps, hamstrings, and popliteus have also got some role in the biomechanics of the PCL in the knee. Like contraction of the gastrocnemius muscles also significantly strengthens the PCL when the knee is flexed at the greater than 40 degree of knee flexion. Whereas quadriceps contraction reduces the strain in PCL when the knee is flexed between the 20 and 60 degree. In contrast, when we see the isolated hamstring contraction, it might destabilize the knee joint in the absence of PCL because of its posterior shear on the tibia in the flexed knee. And the popliteal muscles shares the role of the PCL in resisting posteriorly directed force on the tibia and contribute to the knee stability when PCL is absent. So popliteal muscles also gives the secondary stabilizer when the knee is in the knee PCL is absent. So in this picture, we can see that when the knee flexes, the anterolateral bundle becomes tight and swings up to a steeper orientation, whereas the posterior medial attachment bundle moves towards the tibia and there is the slackening of the fibers. When the knee goes into a deep flexion, the anterolateral bundle becomes more steeper and meets the roof of the nodes. Here, the PCL is vulnerable to impingement against the tibia in hyperflexion, whereas the posterior medial bundle becomes tight and well aligned to resist posterior draw when the knee is in deep flexion. In the extended knee, the posterior medial bundle is aligned to resist hyperextension but not posterior draw. Here, the anterolateral bundle is slack and takes a curved path, which can be seen in the MRI. So in the MRI, we can see that of sagittal section of the MRI of the knee, when the knee is in the full extension, the orientation of the PCL is little bit curved orientation is there. As the knee flexes goes on, we can see that the orientation of the PCL is changing and gets more vertical. And when the knee is at the deep flexion, that is under 20 degree, we can see that the orientation of the PCL is more vertical than when the knee is in full extended. DFM et al. Reported that the PCL undergoes complex 3D deformation during weight-bearing flexion, including changes in orientation and twist of the PCL. They have also mentioned that the two bundles, that is the anterior, the two bundles of the PCL have minimal lengths at low flexion angles, that is in the full extension, and the maximum length is found in the high flexion angles. So this can be demonstrated by these pictures where in this picture we can see that the length of the anterolateral bundle increased and posterior modal bundle is decreased with the increase of knee flexion angle from 0 to 45 degree and then from 60 to 120 degree. Ahmed et al. Study about the condominance of the individual PCL bundles and analysis of the bundle lengths and the orientation. And they have reported that the orientation angle of the anterolateral bundle changed little during the first 30 degree of flexion. And once the knee goes beyond the 30 degree of the flexion, the orientation of the anterolateral bundle becomes more vertical and posterior medial bundle becomes more horizontal. Another study done by the Wang et al. And they study about the effects of knee flexion angle and loading condition on the end-to-end distance of the PCL. And they have stated that the end-to-end distance was lowest at full extension of the knee for both the bundles. And as the knee flexion increases, the end-to-end distance was also increased in both the bundles. So they have concluded that both bundles of PCL were longer in flexion than in extension. We all know that the strength of the PCL is one of the strongest ligament. The tensile strength of the PCL is well documented in the literature and ranges from 739 to 1627 Newton. The majority of the strength of the PCL comes from the anterolateral bundle, as the tensile strength of the anterolateral bundle is approximately 5 times more stronger than the posterior medial bundle. Rest et al. Studies about the mechanical properties of the two bundles on the human PCL ligament, and they have suggested that the anterolateral bundle of the PCL is the more important posterior strength because it has greater ultimate strength and cross-sectional area when compared to the posterior medial bundle. If we talk about the tibial posterior translation, as we all know that the PCL is the primary restraint to posterior translation of the knee, and its effect is throughout the functional arc of motion, and its effect is greatest at the high angle of a knee flexion. In this diagrammatic picture, we can see that when the knee is flexed up to 0 to 60 degree, there is no significant difference between the posterior translation in the intact knee group and in the PCL ruptured knee group. But if we see at when the knee is flexed at the 90 degree, we can see the steep curve rising up in the PCL ruptured group where the posterior translation is more. So when the PCL is tear and knee is flexed at the 90 degree, we get a maximum posterior translation in the knee flexion when it is kept at 90 degree. In addition, the popliteus muscles may act as a restraint to posterior translation in the PCL deficient knee too. Kumagi M. et al. Conducted translational measurement in the anterior to posterior plane on cadaveric specimen before and after PCL section. They found no difference in posterior translation below 25 degree of knee flexion, whereas displacement increased significantly between 25 to 90 degree of flexion, and averaging there was more than 10 mm of posterior translation at 90 degree of flexion. Arnocidi et al. Did a study on the effects of popliteus muscle load on in situ forces in the PCL ligament and on knee kinematics. And they state that the PCL tear, not only did the posterior tibial translation increases as the knee flexion angle increases, but statistically significant decrease in the posterior tibial translation was found with the addition of simulated popliteus muscle contraction. So they concluded that the popliteus muscle is an important stabilizer against posterior tibial translation in the PCL deficient knee. Rotational and medial lateral stability. PCL role in the rotational control of the knee is still unclear. It may act as a secondary stabilizer to rotational force, particularly at the high degree of flexion. There was a study done by the Ram Prasad et al., and they have considered the medial lateral orientation of the PCL. The deviation of the anterolateral and the PM bundles decreased from 0 degree of flexion to the mid-range of the flexion and increased thereafter. And they have also stated that at maximum flexion, the AL bundle is oriented more towards the medial side of the tibia than the posterior medial bundle. A ligament with a more medial orientation may be more efficient in resisting lateral translation. The higher deviation angle suggests that the anterolateral bundle may be more efficient than the posterior medial bundle in resisting the lateral translation of the tibia in high flexion. Joint contact pressure. There was a study done by McDonald P. et al. About the biomechanical analysis of the joint contact forces in the posterior cruciate deficient knee. And they have stated that posterior subluxation of the tibia at 60 degree of flexion in the PCL deficient results in increased contact pressure, and the pressure concentration is increased in the medial compartment and the patellofemoral compartment. This may explain about the long degenerative changes observed in the medial compartment in the deficient knee of PCL. Meniscal and chondral degeneration. Hamda et al. Looked at 61 patients with acute isolated PCL tears characterized as grade 2 plus or higher, and found that 28% of these patients had meniscal tears, commonly involving the anterior horn of lateral meniscus, and 52% of them have chondral injuries, commonly the medial femoral condyle. So they have recommended for the clinician to have a high index of suspicion for concomitant pathology in the menisci or cartilage when evaluating patients with presumed isolated and high-grade PCL injuries. Now going to the clinical relevance about the biomechanics of the PCL. Although the biomechanical function of the PCL is known to be a primary as a restraint to posterior tibial translation, but the clinical relevance comes whether or not operate or do the reconstruction will allow the patient to return to normal or normal activities, and whether residual posterior laxity will negatively affect subjective and functional outcomes. Boynton MD study about the long-term follow of the untreated isolated PCL ligament in the deficient knee, and they found that the patient treated non-operatively for high-grade PCL tears, there were 76 to 85% of patients returned to sports or activity, normal activities, but they had some limitation and decreased performance, especially with the high-speed running. Isolated tear of either bundle does not result in clinically significant increase in posterior translation of the tibia. Complete sectioning of the PCL has reportedly led to significant increase in the posterior tibial translation as the knee flexion increases. Patients may tolerate a PCL deficient knee, but it has been reported that the PCL deficient knee results in distorted loads and different kinematics during functional activities. About the reconstruction of the PCL, single bundle or double bundle reconstruction provides biomechanical superative. Which one? But it's a debatable one, so I will not go into details. But the outcome outcome of the single bundle or double bundle reconstruction depends upon the many factors. The factors are maybe graft choices, tensioning techniques, tunnel positions, fixation methods, post-operative rehabilitation protocols, and of course the surgeon expertise. But Q et al. Have done a study about 4 years ago in 2016, and they have done about the systemic review of double bundle versus single bundle posterior cruciate ligament reconstruction. And they have stated that double bundle reconstruction was significantly superior to single bundle in biomechanical studies, and clinical outcomes showed no significant difference between the two PCL reconstruction. So there was study done by the Race et al. And the Harner CD et al. About the biomechanics of the single versus double bundle reconstruction of the PCL, and they have demonstrated that reconstruction of the anterolateral bundle alone does not restore normal knee mechanics. Posterior medial bundle also support in reducing posterior tibial translation when the knee is in flexed position, which further suggests that both bundles are functionally important throughout the entire range of knee flexion and extension. Recently, most studies have shown that knee kinematics are better restored with double bundle than with single bundle techniques. There are a number of biomechanical questions related to the use of double bundle reconstruction of the PCL. The questions may arise that what exactly does a second posterior medial graft add to a single bundle anterolateral reconstruction, or which reconstruction best restores intact knee levels? So this answer can be done through this diagrammatic one. And as the knee goes from full extension to full flexion, the posterior medial bundle becomes better oriented to resist posterior tibial translation, while the anterolateral bundle becomes less oriented when the knee goes from extension to flexion. So due to increasing horizontal orientation of the posterior medial ligament bundle puts the ligament's returning force vector more in line to resist posterior translation, due to which double bundle or the posterior medial ligament reconstruction may give the further advantage regarding the resistance of posterior translation. So from the key points from this presentation is that the PCL is main stabilizer of the knee joint and serves primarily to resist excessive posterior translation, whereas secondary stabilizer to rotational forces, particularly at the high degree of flexion. Posterior cruciate ligaments have got two bundles, anterolateral bundles and posterior medial bundles, which function independently, with the anterolateral bundle acts primarily during flexion and the posterior medial bundles act in knee extension, but they are working synergetically throughout the arc of motion of the knee. Anterolateral bundle of the PCL is more important in the respect of posterior restraint because it has greater ultimate strength and cross-sectional area. PCL deficient knee results in abnormal loads and kinematics during functional activities, so it is important to restore the reconstruct the PCL. Double bundle PCL reconstruction significantly superior to single bundle in case of in aspect of the biomechanical studies, but clinical outcomes showed no significant difference between the two PCL reconstruction. Thank you for your attention.
That was an excellent talk, Vijayendra. You made very difficult topic very simple to listen to. Are there any questions? Sushil?
Vivek?
Yes, sir.
I had a question. I actually typed that question, but went into Bhadra Dr. Bhadra's private message.
Okay, sir.
So just want to repeat that question by asking that what is the role? There are so many debate going on the meniscofemoral ligaments, the Risberg and the Humphreys ligament. So what is the role of Risberg and the Humphrey ligament in the biomechanics of the knee joint?
Sir, as Dr. Sushil also have stated in his diagram that the posterior medial, that ligament is in the anterior and posterior to the posterior medial bundle. And one of the diagram in my presentation have showed that when the knee is in the when the knee moves from extension to flexion, sir. So during the more than 90 degree of the flexion, the horizontal orientation of the posterior medial ligament puts the ligament restraining force to resist more posterior translation, sir. So it gives the added support for the posterior to resist posterior translation during the flexion of the knee more than 90 degrees, sir.
Amit sir?
Yeah, Vivek.
Sir.
Any more questions, sir?
No, not from my side.
Question, I think.
Okay, Sushil, please go.
Okay, there is one question from Jagadish Thapa. He says, stress X-rays at 90-degree flexion has important role in diagnosing and grading PCL injury. I mean, he wants to say the kneeling X-rays, plain X-ray. Similarly, does the position of knee, flexion or extension, has any role in diagnosis of PCL injury on MRI?
Vijayendra, I think he, I will paraphrase this. He wants to ask whether the MRI of knee for PCL injury can be taken in different positions of knee. Vijayendra.
Yeah, it can be taken, but as I have stated that the orientation of the PCL changes. So we should be oriented to the PCL anatomy in the flexion or extension of the knee. So as when the knee is at the full extension, we can see that there will be the curved orientation of the PCL is seen, whereas the knee flexion is increases, then at the deep flexion we can see the vertical orientation of the PCL. So it's better, we normally do our MRI in the full extension. So we diagnose the PCL in the full extension where we see the curved structure of the PCL. But if
only the other day I talked to one radiologist in CMS about whether we can perform the MRI at 90 degree of flexion, and for the distance between the PCL tibial attachment and the popliteal artery. He says that we need dynamic weld to perform that kind of MRI, and we don't have that kind of MRI available here in Nepal as much to his knowledge. So is it so?
Yes, I think perhaps Amit sir, Ishwar sir, and other seniors can answer this well.
Yeah. Actually, the question was the posterior drawer stress views for PCL. So will it change if you do it in internal rotation or external rotation? I think that was the question that Dr. Jagdish asked. And definitely it will change because of the locking mechanism, the orientation of the condyle, but I think it is suggested to do in neutral position. So the posterior stress X-rays are suggested to do in the neutral position.
Okay, thank you, sir.
Okay.
Okay, Dr. Vijayendra.
Hello, sir.
Very good presentation. Very difficult, complex topic. The biomechanics of posterior cruciate ligament injury, and it is associated with the other injury also, like posterior lateral complex injury or the posterior medial complex injury. Okay, if there is isolated, how do you know on clinical examination that there is like isolated PCL injury is there, or there is aided injury, associated injury of posterior lateral corner and posterior medial corner? So as we with a translation of tibia.
Yeah, as we know that at the knee flexion at the 90 degrees, sir. So when the knee is flexed at the 90 degree, we have got the more posterior translation, and at the knee flexion at the 90 degree, there is the role of the posterior medial bundles. So if the translation is more around before the 90 degree of flexion, then we can know that there is a tear of both anterolateral and the posterior medial translation. But when during the 90 degree, we can see that at the 90 degree knee flexion, there is the posterior translation of the posterior medial bundle, sir.
Okay. Here, even in normal situation, up to 5 millimeter posterior translation can be there. It is said in if you see in biomechanics. If there is isolated tear of posterior cruciate ligament, up to 10-12 millimeter can be there. But if it is more than that, then there must be associated posterior lateral corner or posterior medial corner. And is there any role of popliteofibular ligament? Does it assist on the posterior translation of this tibia also?
Yes, sir. There is the role of the muscles also. So it gives the extra stabilizer against the posterior tibial translation, sir.
Because the PCL itself, it prevents posterior translation of tibia in the deeper flexion.
Yes, sir.
In the in the more extended position, that is prevented by more by the posterolateral and posteromedial complex.
Yes, sir.
And among them, popliteofemoral ligament acts as a dynamic stabilizer, and
Yes,
it provides posterior stability in all arc of motion of the knee.
Okay, thank you, sir.
Thank
Now,
you.
what about role
Yes,
like PFJ problems, patellofemoral joint
There is
problems?
a problem that I have talked about the joint contact pressure. So when there is the posterior subluxation of the tibia, so there is a result in the contact pressure in both the compartments, in the medial compartment and in the patellofemoral compartment also, sir. So due to the joint contact pressure, there is a high chances of the degenerative changes observed in the medial compartment and the patellofemoral compartment when the PCL is teared, sir.
Yeah, along with that, there will be change in patellofemoral contact area also, because rotation instability of the tibia and following the injury of the PCL, that also increase the chance of patellofemoral injuries,
Yes,
the condyle injuries.
yes, sir.
Okay.
Thank you, Arjun sir. I think there are no more questions. There are some questions in chat box. I think that will be answered in panel discussion. So I think we will proceed on to panel discussion. For panel discussion, we have our eminent faculties. Let me share my screen. So, my screen visible? Vijayendra? Vijayendra?
Yes, go ahead, Vivek. Go ahead. Yes.
Yes, Vivek, go ahead, sir.
Okay, let us start our panel discussion on PCL. As the name of our webinar series is ASON Basic Webinar Series, but talking about this PCL is never going to be basic. So I think some complexity will be there during this discussion. Okay, so to talk about, for today's panel discussion, we have our eminent faculties. Dr. Amit Joshi, Dr. Rajiv Raj Manandar, and Dr. Naveen Karn sir, and myself, Dr. Vivek Basagala, will moderate this session.
Vivek, you can kind of minimize your, yeah, good.
Yes, sir. Thank you, sir. That's what I'm doing.
Minimize your video so that it doesn't come into the slide.
Okay, okay. So let us start. So PCL, not very long ago, used to be considered as Lord Voldemort of the Harry Potter series, the ligament one which must not be named. What I meant by this is, few years back, we didn't used to talk about PCL. Talking about PCL used to be considered, surgical treatment of PCL used to be considered as a taboo. But time has changed. Now we are talking about PCL. So don't talk about the journey from don't talk about PCL to let's talk about PCL. The credit goes to all the seniors, many of whom are present today in this platform. So my regards to all of them, and let's start to talk. So I would like to start with Naveen sir. Sir, how common is PCL injury in your practice?
Vivek,
Yes, sir.
before you start, the thing that is coming is from YouTube. I think it's from YouTube because we can see your two pictures and then अलिकति यो के भइराछ किन यस्तो भइराछ ब्लर आइराछ मेरोमा मात्रै हो कि सबैकोमा त्यस्तै हो
Yes, posterior tibial trans.
अलिकति ब्लर
Sir, how common is किन
त्यही त तिम्रो त्यो
YouTube को स्क्रिन आइराछ विवेक तिम्रो सफारी डाउन गरेर अनि तिम्रो जुम
Okay, let me do it again.
तिम्रो YouTube आइराछ
Let me do it. Next. अहिले ठिक छ सर
अब त्यसलाई उस्तो गरौँ न
फेरि YouTube नै हो तिम्रो यो पनि YouTube नै आइराछ
YouTube स्ट्रिमिङ अफ गर्नुपर्ने हुन्छ कि उसो भए
हैन YouTube लाई बन्द गर्देऊ न किन why you are keeping open the YouTube close the YouTube and run your Zoom
okay अहिले कस्तो छ सर? अहिले ठिक छ?
दुईटा देखिरहेछ
YouTube
फोकस छैन
पर्छ होला उसो भए।
अहिले ठिक छ
YouTube मा जुन हामीले शेयर गरेछौं नि सर,
त्यो पनि तिमीले खोलेर बसेका छौ. You don't open that. You have shared. That's it.
No, I have
just closed.
I have closed it. YouTube I have closed.
अब तिम्रो Zoom बाट जाऊ न, तिमी Zoom बाट जाऊ न.
Okay. Is it okay, sir? Now?
अब now it's okay.
Okay.
अब स्लाइडमा जाऊ न.
Sir?
Yeah, this is okay now.
Okay, thank you, sir. Naveen, sir.
Yeah, Vivek, actually isolated PCL, if you say it's very, very less, if I have to give the percentage, is less than 5% of all knee injuries I see. Isolated PCL.
And PCL associated with other conditions, sir?
Yeah, then the chances increases, maybe 20-25%.
Rajiv, sir, same question to you, sir. 5% and 20%.
I think I agree with Naveen. I think I agree with Naveen.
Okay, Amit, sir. Same question.
I don't know. I just missed. The incidence is pretty high, but I take very few for surgery, selected cases. The incidence is not that low, only because we calculate only those things which require surgery as a PCL injury, but these are not that much low.
Okay. So what percentage of your cases are isolated PCL tears that undergoes surgery, and what percentage are the combined injuries?
Very few, less than 5 is for isolated. Most of my are combined injuries.
Okay, sir. So my questions to Rajiv, sir. As I have mentioned in previous slides, PCL surgery is not very old in our country. So since when have you started doing PCL surgery, sir?
Maybe about 3-4 years.
3-4 years. Okay, not very long.
Yeah.
Naveen, sir.
Yeah.
See, if you just talk of the bony fragment at the avulsion one, then I used to do from maybe 10 years earlier, in residency days only. But when you talk of isolated mid-substance tear, then maybe 3-4 years only.
Okay, those avulsion fractures you used to fix arthroscopically or open, sir?
Open.
Okay. Amit, sir, since when have you started doing PCL surgery? Amit, sir?
Yeah. PCL surgery arthroscopic, or you are talking about
arthroscopic
open
PCL.
only?
Arthroscopic PCL.
Arthroscopic I started in 2008.
2008. Okay. And only, sir?
Sorry, Vivek. Hello. Can you come again?
You started with only PCL reconstruction, sir?
No, my senior used to do only PCL reconstruction. I never did. I have assisted him for only PCL reconstruction. I never did only myself. I know only arthroscopy.
So,
Vivek, can I make a comment here? If it was somebody I was training with or my senior, we started off long time back also. But me personally, I've started since 4 years.
Okay.
Yeah, of course.
So like Amit only, I think 2008, 2009, Shizar and all, everybody was doing it. I think I agree with Amit on that. Yeah.
Yes. So message from this slide is PCL surgery is not very old in our country, and because of all our seniors, because of their effort, we are now talking about PCL today, and the PCL incidence of PCL tear is very low. The isolated PCL is very, very low, as our panelists all agreed that less than 5% of their PCL cases are isolated. So what are the usual mechanism of injuries in your PCL patients, Rajiv sir?
Mainly, it's a dashboard injury. It's a dashboard injury, and if some of them come following a knee dislocation.
Okay.
Okay, so they basically, some of them could be just people who get their foot caught in a small pothole. Okay, and then the knee rotates and twists, and so after road traffic accidents.
Hyperextension type injury, right, sir?
Yeah, hyperextension type injuries, and then road traffic accidents. Usually, these sort of people.
Okay, Naveen sir, same question. What are the usual mechanism of injury those patients presenting to eastern part of Nepal?
Yeah, basically it is a combined PCL with the other associated ligament, and the commonest mode of injury is a roadside traffic accident. Very rarely I get a sports type of injury, and the mechanism, as Dr. Rajiv said, it's a basically dashboard type of injury that come common.
Amit sir, I think most of the PCLs, you have the large volume of PCL surgery. What are the most common mechanism of injury in your practice? Amit sir? Amit sir? Okay, I think here we have lost him. So most common mechanism of injury in PCL injuries are either the direct blow to anterior tibia that leads, that is just like a dashboard injury, and hyperextension injury like Rajiv sir just mentioned, and fall over the flex knee with foot implantar flexion. These are very common, very common in day-to-day activities. So the PCL injuries are common. And so my question is, what are the symptomatology of these PCL injuries patient? I want to start with Amit sir.
You see, the symptomatology of PCL is completely different than ACL, since it is a posteriorly located structure. If it is an isolated one, then patient probably will have not much of sign and symptom until unless next day he feels a bruise in the posterior or the posterior medial aspect of the knee. Whereas if it is an associated injury, then the patient comes with the multi-ligament injury. If it is a part of multi-ligament injury, then they come with the dramatic presentation, but for PCL, isolated PCL injury is very rarely detected in early stages until unless you have a very, very high degree of suspicion. These are very commonly missed.
Is there any signs in acute knee injury setting that you should suspect that there may be possible PCL injury?
Sorry, Vivek, can you come again?
Are there any signs, the telltale signs of PCL injury in acute knee injury settings, sir?
Sorry, Vivek, can you continue with some question, because my internet is very fluctuating. I'm trying to shift my internet from one to another.
Okay, Rajiv sir, same question.
Yeah.
Are there any
So,
telltale signs? Yeah. Yes, sir. I think you have heard it.
Yeah, I've heard it. You're talking about an isolated PCL.
Yes, sir.
So, Vivek, isolated PCL, as Amit already said, they come with minimal signs and symptoms. Initially, they'll come following a knee injury, right?
Yes,
but
sir.
if there's a bony avulsion, you have some PCLs with a bony avulsion. So that may present with a lot more, maybe a ecchymosis or, a hematoma that way. Otherwise, it'll just come with minimal signs and symptoms. Sometimes you may be surprised an isolated PCL may just walk into your OPD also.
Yes, exactly. So
Okay,
message
so
from the
that's
slide is
possibility.
that the ecchymosis at the posterior aspect of the
If there's, especially if it's in bony avulsion,
that is telltale sign of the PCL injury. Sometimes it may be even present in the PCL substance there, because PCL is the extra synovial and extra capsular structure. So the blood may trickle down into the subcutaneous area, and it may present as the ecchymosis in the posterior aspect of the knee. So, as we all know, ACL has some typical history, which we summarize as limp index. So, are there any typical history?
I want to add one thing.
Yes, sir.
Usually the ecchymosis in the knee, anywhere if you see ecchymosis or bruising, you suspect that ligament has gone. Besides that, in case of PCL, as one of the mechanism is the dashboard injury, so whenever you see some abrasion or lacerated wound over the anterior aspect of the knee, tibial tuberosity region, then also you always examine the PCL, because that is the indirect evidence that injury is so high, anteriorly it is causing wound and the PCL might have gone. So that is the indirect evidence. If you are finding, always examine for PCL.
Yes, sir. Points well taken, sir. Are there any typical histories, sir? Naveen, sir?
Yes.
Just like in ACL, we have limp index, the very typical histories. Are there any typical histories in PCL injuries?
Classical history like limp and all those things is not seen in PCL. Usually patients say that his or her knee doesn't look very good. The instability sort of thing is very, very rarely patient present come with the instability. They just feel that it is not very good in acute cases. In the very subsequent cases, very late old cases, you might come with the patellofemoral osteoarthritis, anterior knee pain, or the medial tibiofemoral osteoarthritis. Otherwise, the classical symptoms are not there.
What are the main symptoms of the patients with chronic ACL, chronic PCL tear, that we suspect that okay, this patient might be having PCL tear? What are those symptoms?
One is easy fatigability.
Vijayendra, excuse me, sir. Vijayendra, can you please mute?
Vijayendra is muted.
Yes, sir. I'm there.
No, you can see, you can hear from where the sound is coming.
Only the speakers are on mute. All of them are mute. So I don't know where the sound is coming from.
Okay, then. Naveen sir, please continue.
Okay, easy fatigability is one of the feature. Another is the anterior knee pain coming from the patellofemoral joint or the medial tibiofemoral osteoarthritis. Patients sometimes complain of difficulty in squatting because of the pull over there. So these are some of the features they come up.
They complain something about difficulty in going upstairs or downstairs.
Yeah. That is one of the features. Going up a stair, difficulty in squatting, and anterior knee pain is the common features they come with. Instability, very rarely patient complain of instability.
Rajiv sir, same question. What are there typical history in your set of patients?
Yeah, so when you are taking a history, you'll have to differentiate whether it's in the acute setting or, like Naveen said, in the chronic setting.
Okay.
Right.
Yes.
So as in the acute setting, there may not be much of history. Okay. But in the chronic setting, okay, if it's especially PCL in the chronic setting, I think would mainly present with many things, but two significant things. Like one would be patellofemoral pain. I think mainly.
Mm-hmm.
Okay, features of osteoarthritis, basically, mainly patellofemoral pain. And then second would be instability.
Mm-hmm.
So I think these would be the main problems that they would actually
instability
complain.
How do they explain the instability?
They explain that when they climb upstairs, the knee may not be very stable.
Okay.
Okay. The instability will not be that prominent as in an ACL.
Mm-hmm.
Okay, but I think that's how it goes. That's how I think.
Rajiv sir, how long does it take for PF joint symptoms to arise in case of neglected or missed PCL injury?
Very difficult to answer that question, Vivek. I don't do cases in such volume to give you a personal experience, but I think they would take at least 6 months to 1 year, maybe.
Okay.
If you just neglect it.
Naveen sir?
Vivek, can I add?
Yes.
There was a paper by Robert, it's not Smijelski, by Robert Govard, I think. So he said that in chronic, when the patient starts walking, after 6 week of normal walking, the patient starts having patellofemoral pain.
Yes.
But radiological feature of patellofemoral arthritis is much later. So we shouldn't wait till the patellofemoral arthritis occurs. So we should probably be very careful to examine to see the patellofemoral pain.
Yes, sir. So the patients with PCL injury usually presents with diffuse pain, not the pain like in PCL. There will be some diffuse pain. There will be diffuse swelling. There will be discomfort that is more in the flex knee. And in chronic conditions, as our panelist has already mentioned, there will be PF joint symptoms because the tibia sags posteriorly. That's why the femoral condyle will continuously hit upon the patella, and there will be increased joint contact force over the patella and the medial femoral condyle. That's why there will be anterior knee pain, and there will be difficult deceleration. That is, as the person walks on or as the person runs, there will be very difficult deceleration movement, and those patients will complain difficulty with climbing downstairs. Patients will say that involved limb, to put involved limb first than the other limb, it is very, very difficult in case of PCL injury. So these are very typical histories of chronic PCL injury, and we must be very careful. And as Amit sir has mentioned in that paper, the anterior knee pain arises very early as the patient becomes comfortable. As the patient starts working, the patient immediately develops anterior knee pain, and we should not wait till the PF joint become arthritic and X-rays to intervene. Okay. So there are many tests described for PCL injuries, and most of the three main tests are posterior draw tests, posterior sag, maybe palpation or by inspection, and quadriceps active test. So Rajiv sir, what is your workhorse test for diagnosis?
It's the posterior draw test.
Okay. Do you ever do quadriceps active test, sir?
Rarely.
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 And posterior sag?
Posterior sag, yes, I do examine posterior sag. But my main test that I do is posterior draw test.
Okay. What do you see in posterior draw test, sir?
Posterior draw test, basically, I first examine from the side, putting both knees at 90 degrees and observe whether...
Just like in ACL, we see excursion and endpoint.
Yeah. Oh, that's what you're talking about. Okay. So I see the excursion and the endpoint. Here, the excursion is also important.
Okay.
Okay. Here, the excursion is also important. Because do you want me to continue on that?
Yes, sir.
Because depending on the amount of excursion, I need to assess my grading also. For example, if I feel it is grade 3, then I expect that the translation will be more than 10 millimeters. So that is what I'll be trying to assess. And all these factors I will be taking into consideration to whether I want to treat this isolated PCL conservatively or operatively.
Naveen, sir?
See, whenever I put the knee in the 90-degree flexion, first of thing I palpate is the tibial offset at the posterior sag. If I find there is some mismatch in that offset, I go for the quadriceps acting followed by the posterior draw test. If the tibial offset is all right, then I could go with anterior and posterior draw test. So is the offset determines me how to go. And the important workhorse of course is the posterior draw test. And a translation, as Dr. Rajiv said, same way I also interpret.
To grade as 1, 2, 3 sag, do you grade it with the posterior draw test or the posterior sag?
See, when the offset is not there, tibia is going posteriorly, just a little bit has gone. That is the grade 1, I think. When it's coming up to the level of the femoral condyle, grade 2. And when I can palpate femoral condyle very easily, and it is sagging completely, then it is grade 3.
Okay. Amit sir, would you like to add?
Yeah, I absolutely agree. I just want to clarify that at present we are absolutely talking about isolated PCL injury, right?
Yes.
Yeah, that is what we have to know. The test for isolated PCL tear and the associated tear is completely different. So I absolutely agree with Rajiv that I do not do a quadriceps active test. This is more of a, for fellows or for your students to teach. But the posterior sag is very, very important. You do a posterior sag, and what Nabin was saying is very important to know that there is a different grading system for posterior draw test and there is a different grading system for posterior sag. What Nabin was trying to explain is the grading of posterior sag. What Rajiv was saying is the grading of posterior draw test, which is more important. Posterior sag grading also gives us certain ideas, but the posterior draw test, which is more important to decide either the patient requires surgery immediately or I'll try a conservative for that patient.
So the message from
Vivek, can I say something? I think agree with both of them, agree with Amit and Naveen. But what Naveen said is very important. That for the beginners especially, that tibia lies anteriorly, and then tibia lies in line with the femur, and then the tibia goes back. I think those are good denominators for the beginner to assess what is happening with the translation. I think I agree with Naveen on that point. It's a good point. Yeah.
So the message from this slide is very clear. There are so many tests mentioned in Campbell, but 3 main tests for diagnosis of PCL are posterior draw test, posterior sag, and quadriceps active. And among these 3, the quadriceps active has more of the academic value than the clinical value. So a posterior draw test, and if you can master posterior draw test and posterior sag test, you can almost diagnose all of the case of PCL. So PCL injury grading. This has been already covered by our panelists, but I want to continue it again. I want to tell it again. Because of gravity, when the patient's knee is kept in the drawer position, that is hip in 45 degree flexion and knee in 90 degree flexion, the tibia sags downwards because of gravity. And what may be mistaken by the beginners is when you do the anterior drawer test, because of posterior sag position, because as the tibia comes from posterior sag position to its normal position, it may seem like there is PCL injury. So to start with the anterior drawer test, we must be sure that the tibia is at the normal position. We have to palpate that normal anteromedial prominence of the tibial plateau before starting the anterior drawer test. So as Naveen sir has already mentioned, normally about 7 millimeter to 10 millimeter, the posteromedial tibial lip is about 7 to 10 millimeter anterior to medial femoral condyle. And in grade 1 PCL injury, this 7 mm to 10 mm anterior prominence is decreased, and but it is not at the level of the femoral condyle. But in grade 2, the tibial prominence is at the level of the femoral condyle, and in grade 3 it is more severe injury. That's why the tibial plateau goes posterior to the medial femoral condyle. These are the grading of the PCL injury, and this is the grading of PCL sag. And it is very important for decision making during surgery. So investigations, I have mentioned some of the investigations over here for PCL: normal X-rays, MRI, alignment X-rays, and stress X-rays. Amit sir, in a case of PCL injury, what all are there in case of PCL injury? What are your sets of clinical investigations?
You see, this is very important. My baseline is the clinical examination.
Mm-hmm.
I do not treat the PCL injury based upon the investigations. These investigations are accessories for me to identify what are the other associated injury may be present. But the PCL injury is basically my clinical diagnosis. And the treatment is also symptomatic, I decide. Theoretically, you can do X-ray, plain X-ray is always as part of routine. That is important. MRI, I always do MRI because most of these PCL injuries are associated with some other injuries. Alignment X-rays, I look at the again examine the patient clinically. If there is a subjective alignment changes, then only I do alignment X-rays. Stress X-rays, once I thought that very, very important earlier when I started doing PCL in 2008, I thought that stress X-ray must be done to all of our patients. But it seems that the X-ray grading doesn't match with the clinical sign and symptom of the patient. Sometimes you see the grade 3 PCL, the patient is asymptomatic. Sometimes you see grade 2 in X-ray, but the patient is very much symptomatic in case of pain, in case of sometimes instability. So that is why over a period of time, I have reserved this stress X-rays only for very critical cases in which I am in doubt either to go for surgery or not to go for surgery. In that case, only I do a stress X-ray, but my mainstay is the MRI.
Rajiv sir, your take on stress X-ray?
Only on stress X-ray. So stress X-ray, I'd sort of like to, like Amit said, if it is an acute condition, then I would rely more on a clinical examination.
Okay, sir.
Right? But if it was a chronic condition, then maybe I would take the help of a stress X-ray also.
And what about your take on MRI? What is your take
on
MRI?
Yes, so the X-ray, the first thing that you've mentioned there, the X-ray is an absolute prerequisite, right? You know why? Because bony avulsions and all the bony injuries to rule out. MRI, yes, you need an MRI because you must assess the other ligamentous conditions besides the PCL also. So an MRI is a must. And the alignment X-ray, yes, in certain conditions where there's loss of alignment, you might need to do an osteotomy and then do the PCL. So definitely an alignment X-ray is important.
So are there any signs in the normal X-rays, normal plain X-rays that will say that, okay, there might be the PCL injury like the second fracture for ACL?
Yes, lots of it. Like for example, you look at your translation, right? You might find there's a posterior translation on the lateral view. For if there's a gross third grade PCL. Besides that, you look for bony injuries, bony avulsions from the tibia, okay, which is much more common. From the femur, not very common. I think quite rare. And besides that, all the other posterolateral corner injuries, for example, your fibular head avulsions and things like that. So you must look for all that. I mean, combined ligament injuries. That's what you need to see on the X-ray.
Okay. What about your take? What is your take on use of MRI for diagnosis of chronic PCL injuries?
Chronic PCL injuries. For the MRI in chronic, for any PCL injury, I think an MRI has to be done because besides looking at the PCL, there are other structures that you need to see.
Absolutely.
Okay, so that I think takes more importance.
So what about the use of MRI for PCL only?
For you're talking about chronic PCL?
Yes, sir.
For a chronic PCL, whether you
Have
need an
diagnosed
MRI or not.
PCL injury with chronic PCL injury with MRI?
Isolated PCL?
Yes.
Okay, so you've already taken MRI previously?
No. We have not taken MRI. Patient came to us after 3 to 4 months. He has some symptoms of PCL. So you suggested MRI. MRI said something. Can we depend upon that MRI after 4 or 5 months?
On the previous MRI?
No, after 4 to 5 months of injury.
Yeah, 1 second. You said that MRI is taken after the injury? No MRI taken then?
No MRI taken.
Oh,
First
so
MRI
you want to
taken after 5 months.
Yeah. So you're saying that after 4 to 5 months, can we depend on that MRI?
Yes.
Yeah.
My
Now,
question is there any difference between the efficacy or dependency of MRI in acute or chronic situations?
Yeah, the MRI that you would do in the acute condition and the chronic condition. See, PCL injuries heal very well also.
Yes.
Okay, so if you're going to rely on your clinical examination, then that has to be supported by your MRI.
Okay.
Okay, so I think MRI will definitely have a role after 3-4 months prior to your surgery, because there are a lot of other things that you're going to assess. You're again going to assess your posterolateral corner, you're going to assess how the PCL is, and then you're going to assess all the places where your arthritis is going to happen, your patellofemoral OA and everything. I think MRI would be a good idea before surgery.
Naveen sir, I'm going to say this. Yes, sir. Yes, sir.
Yeah, it's to me or Naveen?
You, sir. You wanted to tell something, sir?
Yeah. I just wanted to say that if you do MRI after 6 months of ACL injury, you will see that the ACL has nicely healed.
PCL.
You know, PCL, sorry. The PCL has nicely healed. That is the normal, because if it is isolated, if there are both meniscofemoral ligaments are intact, this will not allow the torn portion of the meniscal to fall back, unlike ACL. So the meniscus will remain. Some fibrotic healing will appear. My point is the decision making of surgery should not depend upon the MRI features.
Yes.
MRI you do to identify what are the other associated conditions. But your decision to go for surgery or not to go for surgery will basically depend upon your clinical examination and the patient's symptomatology.
Okay.
Because the patient may have the patient may have a normal looking, a PCL that is healed but very, very lax.
Yes.
So he's symptomatic, but on the MRI he's got an intact sort of PCL. I think that's what Amit was trying to say, right?
Yeah, absolutely that.
Vivek.
Yes, sir. Many things has been talked about X-ray and MRI. So I would like to have your opinion regarding the stress X-rays for PCL.
Vivek, one second.
Yes.
There is one question by Arjun sir that chronic PCL insufficient, but MRI report is intact PCL. So what do you do?
Okay, we'll come to that first. Sir, role of stress X-rays in diagnosis of PCL injuries. Naveen sir, what is your take on this?
See, always I first do the X-ray. If I found there is bony avulsion sort of thing, then my plan changes. I'll go for maybe CT scan to see the size of fragment or combination. Okay. If it is normal, clinically I am suspecting, I'll do MRI. If MRI is also normal, but clinically I have a doubt that there is problem is there, then I have to have some evidence on basis I will decide for the surgery. Then only I go for a stress X-ray.
Okay.
And if it is significant, then I will plan for surgery.
So if clinically there is PCL tear and on MRI it is normal, then we have to go for stress X-ray, right, sir?
Right.
I think we have answered Arjun sir's question. And regarding stress X-ray, how difficult is it to get the perfect view? Because I also tried once when I was in Dulikhel, but it is very, very difficult for me. Are there any tips and tricks so that we can get perfect lateral view X-ray?
There is a special machine available to get the stress X-ray also, but
Sir, you are not audible, sir. Rajiv, sir?
Rajiv was presenting there. So you have to go to the radio department yourself and then teach them how to do, put something hard over there so that it is a radiolucent thing kept just below the tibial tuberosity, and patient will be hearing weight on that, and you take the true lateral, and then only you will get that. So I think you have to go to the radiology department and teach the rad technician how to do it. It is very difficult. If you leave as such, they will come with some wrong report.
Okay. Amit sir, any experience about difficulties of getting perfect lateral view in stress X-rays?
Yeah, I told you that in my earlier practice of PCL, I used to do stress X-rays for each and every patients of PCL injury. But nowadays it has gone very down. Suppose the example, someone has a normal PCL in MRI, but clinically I can examine that there is a grade 2 plus a posterior sag or posterior drawer test, and the patient is also symptomatic. I'll not go for stress views. So nowadays indication for stress views are very, very limited, and I absolutely agree. If you really need stress views of your knee for posterior sag, probably you have to go yourself and do it yourself, because it's very, very not very commonly done. And you see this X-ray, in this X-ray that you have put,
Yes,
looks
sir.
pretty okay, but this is not a correct X-ray that you need
Yes,
to do.
yes.
You know. Thank you.
So main message from this slide is all of these investigations are important, but final decision making is always by the clinical examination. The amount of sag, the grading of sag, and clinical symptoms of symptomatology of patient decides the need of need of surgery, or those patients can be managed conservative or not. But having said all these investigations, maybe alignment X-rays may be optional, and stress X-rays may be optional, but X-ray and MRI must be done. X-ray to see other bony avulsion injuries, and MRI to see whether other associated injuries are there or not, because PCL, isolated PCL, is very, very rare condition. And picture I have just shown is the PCL, the kneeling stress X-ray view, which I tried to do when I was in Dulikhel, and it was, I think, about after the third attempt, I could not get the perfect view, and I gave up. So after that, what about doing the stress views in OR? Rajiv sir, because everything is controlled, you can get perfect lateral views. We can get the dynamic views as well.
I think that's a very good idea. That's a very good idea. You can do it in the OR.
Naveen
You
sir,
can. You can adjust the C-arm nicely, and yeah, you can do it.
Yeah, you can do it. You can do it. I have never done, but we can do it. It's a good idea.
So I think
I just Rajiv, Vivek, I little bit doubt on what added advantage does it have. So if you want to do X-ray under CM and then decide either you are going for surgery or not, it's completely different ball game. Probably you want to know what you are going to do or what is your diagnosis beforehand, before you take the patient for operation theater and put the patient in CM. But yes, this is a good idea after repair or after reconstruction to check that your things stable or not. Maybe you need to all the things. But I think for the diagnostic purpose, using a CM into the operation theater, it was very popular earlier, especially for valgus and varus, instability. People used to take under general anesthesia, do examination under general anesthesia, and at the same time you do a CM. But the setup is completely different. I think if you are planning for that,
in those conditions, like you have isolated PCL tears and you are confused whether it is grade 2 or grade 3 patient is symptomatic.
Yes, see, you are right, Vivek. See, one very key point that we are missing out here is not all grade 3 require surgery. Not all grade 2 maybe get away without surgery. This is the very confusing point you are trying to say. So some patient, even grade 2 may require surgery. Some patient even have a grade 3 may not require a surgery. So rather than just exhausting your investigation on doing all these things, probably a clinical assessment, the symptomatology of the patient, which is very, very important for me.
So
the thing is, Vivek, when I'll tell you a little thing about stress X-rays. Like when we started doing stress X-rays, we were keeping. I mean, this is how it progressed. Okay, over the years, at least for me, this is how it progressed. So we were keeping the knee in 90 degrees and pushing the tibia. Okay, so now a big fellow goes, pushes the tibia, it becomes grade 3.
Yes.
Okay,
Yes.
smaller guy goes, pushes the tibia, it becomes grade 2. So a little bit of variation was there. Then
Yes.
they were using this KT1000 dynamometer. Okay, and they were quantifying the force and trying to push it back. So I understand exactly what you're trying to say, but I think this stress X-ray would, sort of corroborate your clinical finding, and it would give you sort of go ahead, do the surgery sort of a thing.
Okay.
Right? So if you're in certain cases, like Amit is saying, in certain cases, if you feel, you can go ahead, and that gives you much more confidence to go ahead with the surgery. That's all, I think.
Okay. So I have shown some X-rays in my.
I'll take a few questions.
Yes. Yes.
Dr. Rajiv says, how do we measure in millimeter to grade PCL injury in posterior drawer test?
Rajiv sir, I think Rajiv is asking question. That's why you'll have to answer.
Okay. Exactly. See, he's Dr. Rajiv, right?
Yes, sir.
So Dr. Rajiv, exactly millimeters, I can't tell you. We don't have a ruler there, right? You could probably do it on an X-ray on a stress tube, but it's a clinical judgment. Like Dr. Naveen very well explained to you that if the tibia is positive, then we say that's the point where we start. Okay, so that we would consider as 0. Now, if your tibia is neutral with the femur, then we would say that is about 5. Okay, and if the tibia goes beyond your femur, then we would consider it more than 10. So that would, I think, a very rough denominator is to say to basically grade between 1, 2, and 3. But exact measurements that can only be done on an X-ray with a stress view, I think. Very pertinent question. Nice question.
There is another question by Dr. Nagmani. He says, false positive and false negative test for PCL, how often you have encountered in your practice?
Yeah, I have a very interesting story, I was called by one of our colleagues to operate on a different hospital with the diagnosis of ACL tear, with the diagnosis of ACL tear. I went all prepared with the ACL reconstruction. When I reached there and I examined, it was actually not an ACL, but it was a PCL tear, So what happens when the tibia sags behind and you do a Lachman test? So from the sagged position posteriorly, it comes to the neutral position, and the examiner who is not very aware of will feel that it is coming anteriorly, Actually, it was not coming anteriorly; it was coming from the sagged position behind to the neutral position. So, as Vivek also highlighted, this is a very important thing. Sometimes you can misdiagnose a PCL injury as a ACL injury also.
Nagman, does
that is my experience.
To add to Nagmani question, he has asked about the false positive. As Amit said, if you are just bringing up and it's interpreting it as an anterior drawer test, that is the false positive. Sometimes false negative you will see in the acute cases, there is a big hematoma on the popliteal fossa, and that hematoma prevents the posterior translation of the tibia. So in that case, you might get a false negative posterior drawer test.
Okay, so I have deliberately put this slide over here because there are some subtle signs in X-ray. We all know the signs like the avulsion of fibular head, the arcuate sign and all, and posterior PCL avulsion fracture and all. But there may be some subtle signs like anteromedial and anterolateral lip fractures. These are also very commonly associated with PCL and PLC injuries. So if on plain X-rays, if we see these type of fractures, so we should be very, very careful that there may be PCL injuries. Okay, so we have talked a lot about the stress X-ray.
Vivek,
yes, sir.
Vivek, can you put that slide, because I just want to emphasize on this point, because I don't know if this is one of our case, and I was just trying to explain you that how this has happened. You said that there is a very small flake of bone in the anterior
This is a knee
part.
dislocation, right? It's a knee
yes,
dislocation.
absolutely. Absolutely. There is a very small bone flake on the anterior part. So a general orthopedic surgeon would ignore this because saying that this is extra articular, a very small piece, and this is just ignored because this is a general orth. But why this has happened is because the femur has completely gone forward anterior to the tibia, and this has caused this lip fracture.
Yes.
So this is absolutely, we have to be very careful. You shouldn't leave it. Not only identify PCL injury, but also identify the vascular injury also, which is very, very common with that.
Yes.
That is very important to know.
Okay. So we have talked about a lot about stress X-rays. It has always been a matter of debate, but literature talks about it a lot. there are altogether 5 techniques described in literature, and two of these techniques, one of these techniques, the kneeling stress X-rays views, is doable in our setting. And these are the various the scoring system for the stress X-rays, which I will not go into detail. We can see it in literature. And how we measure in stress X-rays is there are two techniques. One is the Laprade technique. This is the Laprade technique. We draw a line from the posterior margin of the tibial cortex, and we take a point over the posterior most point of the Blumenschartz line, and we drop a perpendicular. The measurement is the posterior sag. Another technique is we draw a line from the posterior tangent. We draw a tangent from posterior margin of the tibial plateau, and draw a margin from the posterior margin of the femoral condyle, and distance between this is the posterior sag. Usually this lies anterior, this is positive, and in posterior sag this goes posteriorly. Okay. So my question to Amit sir, why do we need to treat PCL injury? We used to treat all of PCL injuries conservatively. So what made us to treat these PCL injuries surgically or any conservatively?
You see, my answer to this is little philosophical, and then probably my colleague will agree. There was a time when going into the posterior aspect of the knee is a big issue, because of the vascular. So many approach was not difficult. So many people, they didn't like to go to the posterior part. So if you're surgical in the posterior part of the knee is riddled with so many complications, definitely not many people do it. Once not many people are doing it, then not surgical skills or the surgical modifications are not very fast. The second thing is PCL injury really heals. PCL heals, that we all know it heals.
Yes.
But how it heals is important. It heals in lax position. That is the most important part. So if it heals in lax position, many people will not have a symptomatic knee instability if it is an isolated one. If it is a combination, then instability features are very predominant. But if it is isolated, they do not present. But later on, there are a lot of study which says that there are patellofemoral arthritis, the patellofemoral reaction force is increased, the pain in the knee joint limiting the activities. So if we can do a reconstruction of this thing with a minimal risk of injury, why not to do it? And that is the whole concept that changed, evolved, and many people started doing PCL injury. That is my personal.
So unlike ACL, the PCL injuries, it has been shown that if PCL injuries, the severe degree of PCL injury is not treated, there is in 5 years follow-up, there is chance of medial femoral condyle degeneration in almost 78% cases, and degenerative changes in patella in almost 50% cases. Similarly, because as Sushil has already mentioned, Sushil and Vijayendra has already mentioned, because PCL has some PCL acts in concert with PLC and PMC, there is increased chance of secondary injuries. Just like ACL injuries leads to secondary injuries to meniscus, it has been shown that the PCL injuries, if not treated well, leads to secondary injuries to various other structures around the knee, that is PLC. So it has been shown that the isolated PCL tears, if symptomatic and not treated, there is likelihood ratio of almost 6.2 for development of symptomatic arthritis, and future risk of TKA is very almost 3 times risk of having TKA than the treated PCL injury. Okay. There has been a lot of debate about conservative and surgical treatment about the PCL, and wherever there is conservative treatment, Dr. Selvan comes. Amit sir, what sort of patient with PCL injury you treat conservatively?
You see, if my protocol is very simple. Either the PCL is isolated or the PCL is in combination with other injuries. Okay. If the PCL is isolated, the mainstay of treatment for whatever grade it is, 1, 2, 3, 4, whatever grade it is, the mainstay treatment for isolated PCL injury is conservative. So I'll look into 6 weeks time. I'll re-examine the patient after 6 weeks of conservative management. And then I'll decide either do I need to go ahead with the surgery, or I'll still plan a conservative management.
Sir,
However, this is complete.
What are your
However, this is
conservative
completely
regimen?
different here.
Yes, sir. Sir, please.
Sorry, Vivek.
What are your conservative regimen? Do you prescribe brace? Do you prescribe special type of physiotherapies and all?
I do not prescribe special type of brace. We use if it is a obvious sag. So when the patient comes to you, you put into the knee brace, preferably PTS modified, or whatever we do here is we put a pad onto the posterior part of the calf into the simple brace, and then you start mobilizing and then see that how he's doing. If there is a sag which is a more than grade 2, probably I'll definitely try to give a PTS brace, either the modified one. If it is less than grade 2 sag, I don't put a PTS brace. I just leave the brace and start mobilizing.
Rajiv sir, how you treat conservatively the PCL injury patients?
Conservatively, isolated PCL patients, conservative management, I will apply a brace. Basically, sometimes we apply a pad just below the knee also in that brace, just to bring about an anterior translation. Okay. And then why do we do this? And we give ROM late. Okay. Why do we do this? In the expectation that the PCL will heal. That's why we do this.
So what about weight?
Weight bearing, I will only give after 3 weeks.
Okay.
Okay. Weight bearing, I will give after 3 weeks. Okay. Now, you said the approach, right? So the approach to any PCL, like Amit said, it depends on whether it's an isolated or, let's say, the associated injuries, right? The approach would depend on that. And I think the other things that are to be considered is when the patient presents to you.
Okay.
Okay. So whether it is an acute or a chronic injury. Okay. So these are things that I think you should keep in your mind. What is the profession of the patient? Whether he's an athletic, whether he's an athlete. Okay.
What
so
is your
these things
definition?
I think are to be considered before we consider conservative versus surgical.
Okay, sir. What is your definition of isolated tear? How you define? How you label the patient as this is isolated tear patients?
It's an isolated tear of the PCL. That's all. Are you talking about mid-substance tear,
isolated tear of PCL? How will you diagnose? With the help of MRI, clinical examination,
isolated tear of the PCL? I will diagnose firstly by doing a clinical examination. Okay, by doing a clinical examination, like we talked about, we'll do a posterior draw test initially. Okay, and if you feel that the draw is 2+, right? Or if you don't feel also, you must examine the posterolateral structures. Okay, because they are very, very deceiving. Okay, now if you say there's a patient who comes with a chronic injury, then you must observe right from the gait of the patient. Okay, so you must see how the patient is walking into your OPD, and then you assess your PCL. If your grade is more, you assess the posterolateral structures. You do different tests like your dial test. You assess whether the PCL is torn and the posterolateral. That's how I will assess.
Okay. So whatever grading of PCL injury or whether the PCL is associated with other injuries, the decision making depends upon the age of the patient. That means the activity level of the patient.
Absolutely. Yes.
Symptomatology, where, as Amit sir has already mentioned.
Yeah, especially these will be in the chronic patients who present later.
Yes. Amit sir has already mentioned, even type 3 patient, type 3 grade 3 PCL injury may be asymptomatic, or grade 2 PCL injuries may be symptomatic. So symptomatology also is very important for decision making. Grading of injury is very important. Grade 3 and more are more prone to have symptoms. And associated.
I think if it is a grade 3 patient, you may need to help the patient by telling him what Amit said in the journals, right? Like you showed us a journal. So you should tell that patient, you have a grade 3 injury. So your chances of having, meniscal injury, osteoarthritis, maybe you land up with a total knee replacement. In those situations, maybe you should help him a little bit with literature. And then finally, I think he can decide.
Yes. I was very confused with isolated PCL tear, and in my literature says this is what I found. The isolated PCL tear is when there is difference about 8 millimeter in bilateral knees, in kneeling stress X-rays, if there is less than 5-degree abnormal rotatory laxity between the two legs, and if on clinical examination there is varus and valgus instability, no varus and valgus instability, demonstrating mediolateral instability. Basically, what we all do is we diagnose isolated PCL tear with the clinical examinations only. So I went through some of the literature about the conservative management of PCL tear, and what it mentioned was the conservative management, the protocol of conservative management should be as good as the post-operative PCL, post-operative physiotherapy protocol after the PCL reconstruction. We have to limit gravity. We have to give prone range of motion, not the uncontrolled range of motion. Dynamic bracing, if available, is very, very good. But we have some jugaad technique with us. We keep the some padding over the posterior aspect of the calf, over the calf, so that the tibia is pushed forward. And hamstring innervation must be there for about 2 to 2.5 months. So it is, as the conservative treatment must be designed and must be prescribed as good as the case after the post-operative PCL reconstruction. Okay.
And you must encourage the quadriceps.
Yes, yes.
So we do good quadriceps exercises, especially those extensions and all. Yeah.
Inhibit hamstring. Okay.
Yeah.
So let's have some cases with this background. Rajiv sir. So this is case for you.
Vivek, before you go to the case, I just want to add one highlight that the isolated acute mid-substance tear always goes non-operative treatment, but non-operative treatment doesn't mean there are no treatment. And whatever braces you have shown is very, very costly, number one. Number two, if anyhow patient buy it from anywhere, our physiotherapist doesn't know how to apply it. So you people are using a modified brace sort of thing. At my places, I put plaster. I put plaster in the cylindrical cast for 3 weeks. After that, I take that out and then start with the rehab and then give the brace also, because my patient doesn't understand it properly. So all my isolated acute mid-substance tear, I put cylindrical cast.
That is very interesting. I would like to take opinion of our senior faculties. Arjun Lamisani sir, any input regarding the conservative management of PCL injuries, isolated PCL injuries?
Thank you, Vivek. I think it has already been discussed about the different modalities of treatment. As Dr. Naveen said, I don't have experience so far, or I have not applied cast so far to the patient with the PCL injury. The main aim is to not to allow the proximal tibia to shift posteriorly for around 3 weeks or so. Then with the guarded knee brace with the proximal tibial support, range of movement should be started. The weight bearing should be delayed few more, let's say, around 4 to 6 weeks also, because there will be some rotational during the full extension of the knee. There will be internal rotation of the knee. That also gives stress to the healing PCL that can lead to instability in later date.
Okay. Thank you, sir. So, Rajiv sir, let's come back to our case.
Yeah. So I think, Vivek, this is a very interesting case that we've all been, and I think this deals with all that we've been discussing. Okay. Yes. So a young, active male with a history of 4 months trauma. He was managed conservatively. Now he's complaining of anterior knee pain, and he has pain when he's descending stairs. Now, how do we proceed? So now I'll just recapitulate what we said, right? I think. So why is this patient come now? We probably think that this patient is unstable to a certain extent. Okay. And he has, like Amit said, beyond 6 weeks, probably he has clinical osteoarthritis, patellofemoral maybe, not seen probably on the radiograph, right? Which would be seen much later. So now how do we proceed? So we proceed with the clinical examination. We check his gait, right? Now, when we do clinical examination, there's to be a very, very high index of suspicion on the PLC, the dark side of the knee. That is what is going to trick us. We should not miss, besides the PCL, when we do our posterior draw, we'll get a posterior draw positive, but we must repeatedly check the PLC, do our dial tests, and then I think that should be followed by an MRI.
Okay. Sir, these are the MRIs.
Can you guys see MRIs? I can't see MRIs.
You can't see, sir?
No, I can't see. It's still in case. Okay.
Okay.
Wow, these are small MRIs and quite foggy also.
Okay.
Vivek, I can't see the MRIs very well.
Naveen, sir, can you see it, sir?
The little,
Yeah,
the screen is again blurred. It's coming from YouTube. YouTube is coming from YouTube, I think.
No. It's from Zoom only.
Rajiv, I can see.
You can see. It's a little.
Yeah,
blurred.
there is a tear of the.
So yeah,
ligament. I can see.
I can see that the tibia is translated posteriorly.
Okay.
That I can see. PCL I can't see very well. So probably this is a PCL tear.
Naveen,
PCL
sir,
is absent. PCL is absent.
Okay.
Naveen, I think you can comment because I can't see the MRI very well.
PCL is absent, and in one cut only ACL is seen. So probably that is there. ACL is there. So PCL is gone.
Okay, Naveen sir, please continue. This is the clinical examination. The patient was grade 2 PCL tear, managed conservatively, now having symptoms of tear joint. And this is clinical examination, grade 2 or grade 3 under anesthesia.
Yeah, it's 2+. It appears to be 2+.
Okay, so how will you approach?
So my approach will be to counsel the patient and go ahead for the surgery.
Okay, so transtibial or inlay? Have you had an experience of tibial inlay PCL?
In the earlier, because I was trained in AIMS, so Dr. Mittal used to do inlay. So initial 3-4 cases I done with the tibial inlay technique, but it is so cumbersome, and subsequently, see, both my in practice, both ACL as well as PCL, what earlier I used to do, I changed. Maybe after PKC or the BMP course, I shifted from the this bone tendon bone to the hamstring. Similarly, in this for PCL, earlier I used to do the tibial inlay technique. Now all of my cases are transtibial and hamstring is the graft.
Okay. Arjun Lamisane, sir. Arjun sir, I think we in
Okay.
while I was doing residency in teaching, I have seen some tibial inlay.
Yeah.
Can you share some experience about the inlay?
Previously, we used to do tibial inlay technique with the bone potato tendon bone graft. Now we started doing transtibial with the hamstring graft.
Sir, why did you change, sir?
Because the position was cumbersome.
Okay.
And the patient had to be put on the lateral position. The arthroscopy is done with the rotation of the hip. Okay. And then again, fixing and approaching and fixing was quite difficult.
Okay. Sir,
and there was a large wound posteriorly also.
Okay. Were there any difference in final clinical outcome in your tibial inlay group and past tibial inlay group and present transtibial group, sir?
But the result is definitely, it was better with the bone patellar tendon with the tibial inlay technique.
Okay. So are you still sticking with the transtibial, sir?
Yeah.
Okay. Amit sir, your comment, sir. Transtibial and tibial inlay.
I have no experience whatsoever with the tibial inlay technique. It's all transtibial technique. My techniques are always but I have seen them. And then to tell you very frankly, tibial inlay is more difficult than the transtibial arthroscopic surgery, because you need to change the position, then you have to make certain drill holes, and then it's really difficult. And then you have to give a big incision into the posterior medial aspect of the knee joint that has to go across the knee, and it again has some morbidities. So probably arthroscopy is the good one. We cannot say the recent studies that doesn't say that one is better than another one. Both the results are equal.
So definitely there is longer incisions, there is very bad looking scar in inlay technique, and the arthroscopic technique has very low scar, very small wounds. But as far as final result is concerned, there has been multiple studies, the systemic reviews are available, and which states that transtibial versus tibial inlay techniques for posterior cruciate ligament, there is no difference in final results. So in whatever technique we are comfortable, we can do it. But having said all those things, the transtibial technique is full arthroscopic, so the morbidity will be very, very less in this case. Sir, are there any disadvantages of transtibial technique? Amit sir.
Yeah, absolutely. The theoretical disadvantages are the most known killer curve. If you go from the transtibial technique, there is a killer curve that means in which the posteriorly directed graft suddenly changes its direction and comes entirely. The killer turn or killer curve is the most said disadvantages. But at this moment, hardly this has, because of so many modifications on the surgery, we place our graft much lower, then you chamfering the other part. This has gone lesser and lesser. The killer turn has lesser issues, but that is the only issues I'm.
Sir, I think you have already started it. Are there any techniques to reduce the effect of killer turn?
Yeah, I told you that one technique is you go little down so that you are not up into the facets. You go right at the ridge of the champagne drop off. So if you go little down, what happens? It will go, your graft is down, then it comes up and then goes entirely. So killer turn is diminished. The other technique is then you chamfer the upper edge, the superior edge of the tunnel. Okay. You smoothen the superior edge of the tunnel so that when there is an acute curve of your graft, it doesn't cut with the sharp edge of the tunnel. So those are the things. There are other techniques like all inside PCL reconstruction available, described by many authors, that also avoids the killer turn. There are so many different types of technique, but I do a very standard technique.
Okay. So I have heard and I have studied about killer turn a lot, but I never thought this would be so dangerous. And while preparing for this panel discussion, I went through some literature and it showed that these are the grafts after about 5,000 flexion and extension after the PCL graft was fixed. And you can see at the middle, the graft has been thinned out and pulled. And this is the below one is the electron microscopic view, and it says it shows that the graft actually do tears microscopically because of the killer turn. So killer turn do exist, and there are various techniques that reduces the effect of killer turn. As Amit sir has mentioned, we can bevel the upper edge from where the graft goes, so that the acute bone spike won't attack, won't be gliding over the soft tissue graft. And tibial inlay is one of the technique where killer turn is completely avoided. There is another technique of drilling from anterolateral side, so that the graft goes from anterolateral to anteromedial, so there is little less killer turn than drilling from usual anteromedial side. And there is technique of modified tunnel placement of finally, in which the tunnel is not placed as anatomical location, but it is located more posteriorly and more laterally, so that the killer turn effect is decreased. Having said all those, the clinical results of killer turn, clinical effect of killer turns are not so seen in our practice. I think Amit sir has got most of the PCL patients. Amit sir, have you had any problem with the killer turn, like failure of your PCL surgeries, breaking the graft here?
I don't know. There are some failures of PCL reconstruction, but we don't know what has caused the failure. Either the fixation failure or it is the killer turn that has caused. But these are one of the causes which fails your PCL reconstruction.
Okay.
So whenever possible, you try to avoid those. But it's very difficult to say what has failed your PCL reconstruction. It's very difficult to say.
Sir, for drilling tunnel, I know, yes, Rajiv sir, for drilling tunnel, do you ever use Siam?
We used to, Vivek. We used to. Previously, they used to use a safety incision, put their finger inside, but now all that has become obsolete. We don't use Siam now.
Okay, Naveen sir.
And one thing I just want to mention that I agree to everything that you've said about the killer turn, but one literature that I came across, while reading someday, I remember one author has said the killer turn, it sort of remodels. So maybe, okay, definitely it's a big factor, but maybe that's not only the focus factor where the PCL is failing. Maybe the other factors also why your PCL is. They say that piece of bone, that sharp tunnel, these days, like Amit said, we do a 45 degree turn, right? But that sharp turn may be remodeling. One of the authors had mentioned something like that. So I thought to just bring it to my mind.
That's a nice point, sir. Naveen sir, do you use?
So I don't use the CM. Now I don't use the CM.
Vivek, before answering about CM, I want to say something about one of the things you said that if you go from the lateral to the medial, in spite of going from medial to lateral, I think that is to prevent the neurovascular injury.
No. That prevents the neurovascular injury, and as the femoral tunnel is on the medial side, if we go from the medial tibial side, what happens is there is more acute angulation and more angle change, and it leads to more killer turn. So if we drill from the anterolateral side, it goes somewhat more straight. So killer turn effect is decreased. It has been mentioned in literature, sir.
Okay. Another point I want, besides the Amit said that the taking out the anterior part of it, there are two important points I wanted to say about when you are doing, besides the tibia inlay, I am talking of transtibial. When you have two important things to be taken care of, one about the tunnel. Tunnel is to be central and it has to be more vertical. Even Bancha said he uses 60 mm that jig. But we use 50-50, he used 60. So the central placement and the vertical placement for the tunnel. Regarding screw, it is said that the screw should be quite closer to the tunnel and it should be inferior and medial. If you do that, the probability killer turn is less. Now coming to the question of CM, earlier initial part of practice, I used to use it to confirm that whether this guide wire is coming exactly over there or not. Nowadays, I don't use CM. Whenever I am in doubt for guide wire, then I always check. I'll get the lateral X-ray and confirm.
Okay. So I think none of our experts uses CM. So what is the graft choice, Naveen sir? Because unlike ACL, we need a very strong and thick graft for PCL. What is the graft of choice for years?
My today practice, my graft is hamstring.
Hamstring, you take semi and gracilis.
Semi and gracilis, quadruple.
Rajiv sir?
Isolated PCL hamstring.
What is your minimum size, sir?
Minimum size?
Yes.
At least 9. I try and get the biggest possible.
Okay.
Yeah.
And what is your minimum length required?
Minimum length is at least 9.
At least 9. Okay.
Yeah.
Amit sir?
Yeah, for male, for isolated, hamstring is still choice. But for female, I have burnt my finger many times. So whenever a patient is female and I'm doing a PCL reconstruction, I always counsel for a possibility of the peroneus longus graft. Because the females,
that would be a great graft. That's a great graft. That's a great. Peroneus longus would be a great graft. It's solid, thick. It's a great graft.
So for past many months, for the females, I am inclined to get the peroneus longus. I counsel my patient that I might require to take your peroneus longus. But for male, a huge big size male, I'll definitely, the first choice would be a hamstring.
Amit, is the only criteria only female? What about if the female is playing sports?
There is no relation of sports with the size of the hamstring graft. We also have published that it has very much close correlation with the height of the patient, especially the femoral length of the patient. So the femoral length is very much closely associated with the length and the size of the graft, not the type of sports. And there are so many people who say that type of sports.
I was asking regarding the peroneus longus. You said no. For female, you use peroneus longus.
Yes, a short stretcher female, a very stout, short, a little plump female, peroneus longus is it.
But I am adding that female is also playing sports, professional athletes.
Yes, if there is no difference. There are a lot of studies that have come up with the biomechanical study also for the peroneus longus.
Why I am asking this, Amit? Dr. Bancha has presented a paper regarding this, where his clear-cut indication for taking peroneus longus graft was especially two. What you said, when there is a foot drop and patient has not recovered, then that is one indication he said. Another he said that the cavus foot. But the contraindication side, what he said, if patient is having a chronic ankle sprain And we don't know in the sports that because they are playing the sports, often they have to suffer from some injuries. So if patient is having a sort of chronic, so he in conclusion he said, if you are having a maybe flat foot or sports guy, better not to take peroneus longus as a primary graft, but for revision you can think of it. That was his conclusion.
Yeah, Naveen, you are right. After Bancha, whatever you are saying, after Bancha said, there is a paper of Bancha saying that there is hardly any difference, biomechanical difference in the foot after the harvesting of the peroneus longus. And there are 6 other papers that are presented, including the biomechanical study. Yes, for certain people like, ballet dancers, in which you need a very strong, that kind of ankle, probably a ballet dancer will not be a good idea. I again agree that it is not my first choice, but rather than harvesting a hamstring, which is very, very small and compromising the ACL, I'll definitely counsel the patient for possibility of the peroneus longus. That was my purpose.
Okay. So this was our first case.
My only concern was the peroneus. Yeah, my only concern was whether, like, ask my opinion from everybody. I want an opinion from everybody about peroneus longus as a primary graft. That's the only concern. Otherwise, when we take the graft, it's a wonderful graft for the PCL. It's a wonderful graft for the PCL. But peroneus longus is a primary graft. Like Amit has said, I think we need to do some literature survey and see. That was the only concern that I had. Peroneus longus as a primary graft. Don't know how good that will be. Because of associated, we have worries about ankle problems later on. That's the only, I think that's what Naveen is also trying to address, right?
Okay, I have, sir, I have 2 more cases and it's already 6. Should I continue or we should call it a day?
I think one more.
Some very interesting questions in the chat box. Why don't you take some of those questions in the chat box?
Vijayendra, please come in.
Okay. What question?
Yeah,
yes, please. Are there any questions in the chat box?
Yeah, there are questions that Dr.
Please.
Thapa have asked. Are these chances of degenerative changes of medial femoral condyle and posterior femoral joint arthritis only in grade 3 injury or even in grade 2 or grade 1? If chances of arthritis is so high, then why not to operate in all cases of PCL injury?
Amit sir, I think you have to take this.
Yeah. Let me take this question. We know that more the posterior translation, higher the joint reaction force, higher the chance of the osteoarthritis. That is the rule we know. But what we do not know is what is the cartilage status of the patient, what are the other anatomical factors. These things we don't know. So we don't know what are the patients who are going to develop arthritis or what are the patients who are not going to develop arthritis. Obviously, grade 3 will have higher chance of development of arthritis than grade 2 and grade 1. So rather than preemptively operating, you monitor those patients very closely, and at earliest of the sign and symptom, probably you counsel the patient for surgery. That is my take.
Okay, so another question is about that's Madhu, sir.
Yeah, I think that grade 2, Jagdish, that thing that you're talking about, grade 2 injury. Yeah, grade 2 injury in an active sportsman, right? If he's going to go back and play active sportsman, maybe he'll also develop arthritis. Now, it's a very subjective thing. Now, so this patient, like Amit is saying, after seeing, maybe about in 6 weeks, he's going to come with knee pain. Okay, then you can do surgery. Now, on the other side, you're saying, why not operate all patients? Because they heal. Okay, so you can't operate on a PCL that is going to heal. Isn't it? So you shouldn't operate all patients. Now, grade 2 also, if he's going to use his knee, he's going to go rock climbing, he's going to jump from places, he's going to pursue absolute hurdling, things like that. He's going to also develop patellofemoral osteoarthritis. He's going to come with instability, and then that patient may be a patient that will be reconstructed. Okay. I think that's what I wanted to say.
And another question is about the PCL avulsion injury repair. So how long we can repair the PCL avulsion injury?
Naveen sir, I think you have to take this.
Usually 3 months is the recommended criteria. If within 3 months it has come, then I will go and fix it. More than that, it already lacks, then Even if I will fix, then I will have to be assured that I might not become with the, should be ready with the suboptimal fixation, because the idea is to make the PCL taut rather than the healing. Main purpose is to make the PCL taut. So even in after 3 months also, I will go and fix it.
All arthroscopic, sir?
No, I go with the mini open technique.
Okay, in all PCL avulsion cases, sir?
Right, only the fixation thing. Even if I do mini open, if the chunk is very big, I go with the screw fixation. If it is very comminuted, then I do the pull through suture only, but technique is mini open one.
Okay, okay. Rajiv sir, what is your technique for PCL avulsion? Arthroscopic?
See, the thing is, the PCL avulsion, if it is a bony avulsion, okay, if it is a bony avulsion, usually happens from the tibia. So the technique is arthroscopic. You make 2 posterior medial portals and 2 anteromedial and anterolateral portal. You pass sutures and you can do it. There's a technique described, okay, for bony avulsion. Now, PCL avulsions from the femur, non-bony, PCL avulsions, I have never repaired it.
Okay.
I have never repaired it. I haven't seen PCL avulsions that I needed to repair. So that's what I can tell you.
Are there indications?
If it is bony avulsion from the tibia, yes, I do arthroscopic. Yeah,
sir,
sorry?
bony avulsions of tibia. Are there any indications for open surgery in PCL avulsion? That is the bony tibial avulsion of PCL. Are there
that is a technique that is practiced. There's certain surgeons that go open and put in a screw also. Yeah, but it's not very good. Like Naveen said, if it is a very comminuted fracture, then it is difficult to fix with a screw. No, otherwise, that is a practice technique also.
What I wanted to ask is, sir, are every PCL avulsions amenable to be treated by pull-through sutures?
Mostly, yes. PCL bony avulsions.
Yes.
Yes, yes, definitely. Isolated bony avulsions you can treat with arthroscopy.
Okay, okay. Vijayendra?
Yeah, related to this discussion only, arthroscopic suture pull-out technique is better than open rigid fixation of PCL avulsion. So in the PCL avulsion case, whether arthroscopic suture pull-out technique is better than open rigid fixation or not.
Amit sir,
the thing is, okay.
Sir. Sir, Raj sir, you take it, sir.
Yeah. So basically, see, Vijayendra, if you can do arthroscopic, it's minimally invasive, like less traumatic. And I think arthroscopic results are good because you're going to pull it down. Basically, see, you have a lot of techniques where you can use 2 portals from the back. Okay, it's a very good vision. Okay, so from the high portal, you're looking inside. It is quite comfortable, and it's just passing of sutures, like how you do after a couple of cases. It's like doing an ACL tibial spine avulsion. Okay, that's all. I think it's not that difficult. First few cases may be a little difficult, but I don't think after you do it for a while, it's not so difficult. I think. I don't know what would my other co-speakers say. Yeah.
Yeah, I think we shouldn't discuss which is better, which technique is better, or what technique is. Depend upon if a non-arthroscopy surgeon does a arthroscopic fixation, it's always bad. and a arthroscopic surgeon like me who does an open, I have done few cases, but it's very, very difficult to visualize the small fragment, it's very difficult. So my protocol is, if I can get them within 3 months, which is in that 3 months time, it has not healed, I do a arthroscopic pull-out technique. If it is beyond 3 months, then I'll manage them conservatively and see that if the patient develops symptoms or not, how much is the sagging behind. So if in that case, I let it unite or I say a mal-unite, and if the patient is symptomatic, I'll go ahead with the PCL reconstruction in that case.
See, it has something to do with familiarity also. With any technique, if you're doing for very long time, suppose I can also do maybe arthroscopically fixation of that thing. But thing is that if I do mini open, I will finish in maybe half an hour. If I do arthroscopy, because I am still in the process of graduation only for the posterior compartment. So I might take maybe 2 hours, 2.5 hours. So I'll just do in half an hour. So that is why probably I go with the mini open. Probably when I become graduate for posterior compartment, then I will go just arthroscopy fixation.
Okay.
I think whichever way is not important. I think you should fix it well. That is most important. I think that is important.
Absolutely.
I think you fix it well.
Now, regarding the graft, so apart from the hamstring graft and the peroneus longus graft, can we use quadriceps graft?
Amit sir, please come in.
Yeah, of course, quadriceps graft can be used, but what is the purpose? What you are doing? If you are doing an isolated PCL reconstruction, hamstring is the gold standard. If you feel that hamstring is not a good size, then you can think about either to take a peroneus longus or to take a quadriceps. And to what you are familiar with, you can take. Many people now, they use quadriceps graft as their primary graft for all ACL and the PCL reconstruction. I agree with Navin. To what you are adopted to or to what you have learned, probably you can do. Quadriceps is an equally good graft.
Thank you, Amit sir.
Sir, what is your take?
I think I have a comment on this, right? I mean, this may not be universal to everybody, but I have a comment out here. See, the one test for PCL is a quadriceps active test, right?
Mm-hmm.
So the quadriceps is going to assist the PCL to stay where it is. I mean, basically, it's going to assist anterior translation of the knee. So if you can help it, I think I would say don't go for the quadriceps. Because see, when you take a quadriceps graft, that's going to weaken your quadriceps, which is in favor of PCL. Nah? So I think I would probably go for peroneus longus maybe, or I think hamstring first, maybe bone patellar tendon, or maybe, that peroneus longus, but not for quadriceps, I think.
To add the Rajiv discussion, that there are many people, they say that, of course, that the quadriceps is agonist to PCL. So the many, even Dr. Carlos from Brazil and others, they use quadriceps from the other limb, just to avoid that there should not be. So that is the thing. So ipsilateral quadriceps, again, I have a hints for that. I would support the Rajiv comment.
Okay.
Okay. Now,
sir, Vijayendra, I have a question.
One question more, Vivek.
Okay.
So in chronic PCL avulsion cases, regarding tunnel, is there any consideration in chronic PCL avulsion injury?
Amit sir, please take it.
I didn't understood the question.
Any tunnel?
So during the chronic PCL avulsion repair, we have to consider any tunnel consideration should be taken or not.
Vijayendra, who asked this question?
And Dr. Sanjeev.
I think he has to come and ask himself. Please unmute. He has to unmute and ask himself what he wanted to say.
Dr. Sanjeev, are you there?
Yes, sir. Yes, sir.
Okay.
I just want to ask, in the chronic PCL avulsion, the bony fragment has been chipped up and there is alteration in the bony anatomy where the PCL attaches. So in chronic PCL, where we are planning for PCL reconstruction, whether any internal specific consideration has to be taken, any anatomy, the angulation or something more vertical or something like that, I'm going to ask.
You see, the approach may be different. I don't know, I can understand your question completely, but let me try to answer that by saying that in a chronic PCL avulsion, if the fragment is malunited, probably I'll not go ahead with the pull-out sutures. So I'll do a formal PCL reconstruction and drill at the normal anatomical position. I'll not change my anatomical position. Does that answer to your question, Sanjeev?
Yes, sir. Yes, sir. Thank you, sir.
Amit sir, what is your take on double bundle PCL reconstruction? I think this was, you were asked about this in arthroscopy academic webinar as well. What is your take, sir? The studies have shown that it is biomechanical studies, not the clinical studies, have shown that there is more stability with the double bundle reconstruction, and it is doable, I think, the PCL. What is your take on it?
Yes, sir. See, Vivek, you can debate on anything, You can debate on anything. Main important thing is two things. One is, how do you reconstruct which looks like anatomical? Okay. So if you want to reconstruct which looks like anatomical, probably Sushil clearly said that the femoral attachment is as double as the tibial attachment. Yeah. So probably it makes sense to make a single tunnel into the tibia and two tunnel into the femur, so that you make it more anatomical. Yes. This will look like anatomical, and that is what my practice when I started doing my PCL reconstruction. But the question is, does anatomically looking like PCL functions better than the single bundle PCL? And they're biomechanically in the cadavers, definitely they look like better. But what we are forgetting, nature is there, which will automatically modify the tissue according to Wolff's law. So probably at this moment, there is no obvious advantage of double bundle in my practice. However, If it is a very chronic, there is no remnant of PCL preserved, absolutely empty notch, absolutely non-existence of the any collagen of the PCL. In that case, I'll still tempt to go for a double bundle, but that doesn't happen very often, and most of the time PCL remnant are intact. And if you can preserve some of the PCL remnant, the single bundle PCL is the way to go, I think.
Okay, Rajiv sir, I think your take on this, because the anatomy and biomechanics said that double bundle is better, but we are talking about the single bundle. What is your take on this? A double bundle?
I think I agree with Amit, because see, double bundle is anatomically it sounds it's like a fan shape sort of thing. You're creating both ends of the fan, all that, right? So research has been going on over the years. Then they found an isometric point which didn't work, all that, right? So I think looking at the recent literature till today, I think our practice should be based on what is reasonable for us. We have done double bundles earlier, put 2 screws into the femoral condyle. But see, the thing is, it becomes more expensive also. And what about the results? The results, I don't think, are very different. I have not done many PCLs to tell you what the exact results are, but I think I'm okay with a single bundle till now. And the literature that I refer to, I think there's not much of difference between a double bundle or a single bundle in the function of the patient. Okay, so the functional outcome, I don't think there's much of difference.
Okay. So while I went through the literature review, unlike PCL, in PCL, the femoral tunnel, the location of femoral tunnel is very debated thing. But in PCL, the location of tibial tunnel is very debated thing. Some say it must be at the center, some say it must be somewhat medial, some say it is somewhat lateral. What is your perfect tibial tunnel placement during your PCL reconstruction? How do you do it?
Vivek, I think, okay, so tibial tunnel. So tibial tunnel, I think there's this very useful technique that is known as the transeptal technique. Okay. Previously, when we were doing PCLs, what we were doing is we were cutting everything. Okay, so we were using one posterior medial portal. Okay, this is, I think, maybe for the juniors it'll be a little slow, but we were using one posterior medial portal and 2 portals from anterior, and we were doing our PCLs. So we were removing everything from the medial epicondyle, getting a good view, and going back and putting that portal, and everything was good, right? But now is the concept of remnant preservation. I think Amit will be also, Naveen also will be able to highlight on this. That's the latest concept now. Basically, when you preserve the remnant, like in ACL, right? It preserves it brings about a scaffold, it brings about good blood supply, leads to good healing, and your overall PCL graft is very good. Okay. So what we do is, like Sushil was saying, it's quite easy. It's not so difficult. You put in a Vijayendra rod from the medial side and do a transeptal technique. So now in this technique, we are viewing from the lateral side and working between the other portals, right? So we put a jig from the posterior medial portal. Okay. So, and we are looking from the posterolateral portal. So we mostly can see where the remnant of the tibia lies. So that is where I'll take out my drill point.
Okay.
I think in time that has been the most reliable thing for me.
Yes. Okay. Thank you, sir. So I think we will stop it. So take home message after today's panel discussion is always see and feel for posterior tibial sag. Grade 1 and grade 2 can be managed conservatively, and most of the patients with grade 3 isolated tear and concomitant injury are the surgical indications, but those deciding factor which we have already mentioned during our panel discussion must be seen into. And whenever in doubt, do stress X-ray. I have mentioned this in my take-home message, but I think this is no more valid after our panel discussion. So single bundle reconstruction is still the valid option. Though in biomechanical studies, double bundle reconstruction has shown better results, but there are no clinical studies which showed that double bundle reconstruction is better than the single bundle. So single bundle reconstruction is still a valid option. Thank you so much. Thank you so much to our esteemed panelists. Thank you so much to all the attendees. Thank you so much to seniors. Thank you. Vijayendra, are there any more questions?
No, Vivek, I think it's already done.
Okay.
Naveen sir, Vivek, I have one question for Naveen sir.
Yes, Vivek. Yes.
Sir, as part of the conservative management of the PCL tear, you said you apply cylindrical cast. So how long do you apply the cast?
3 weeks.
3 weeks.
3 weeks followed by the ordinary brace, what we are having with the posterior pad for another 3 weeks, and then out of brace then, and the proper physiotherapy. That is important.
There is
See,
very interesting.
usually what happens whenever any CME or any places we say that the no surgery, then our orthopedic surgeon or other colleagues understand that it is not. Many of the cases I have seen come to me PCL injury with nothing, because it was isolated injury, so doctor said nothing is to be done. So they are just with the sagging knee, they are moving here and there. So there has to be proper physiotherapy, as well as if you are immobilizing, it has to be given properly. I put absolutely like we do for fracture patella, I give for 3 weeks. After then I assess the stability and put on the brace for another 3 weeks, and then gradually start the physiotherapy, especially focusing on the quadriceps.
So you have not come across the stiffness of knees, sir?
No. After 3, you see, you are keeping fracture patella for 6 weeks, but hardly you see any stiffness. I am keeping it for just for 3 weeks. But even if I am keeping the cast, and then I ask patient to mobilize the ankle as well as to do the quadriceps drill, that the static quadriceps drill, to lift the limb, make it quadriceps tightening all the time. The quadriceps drill with teach, no? Even in the cast you can teach. It's not that he has just left limb as such. In the cast also he can do the quadriceps physiotherapy.
Yes.
I think, I think we should be heading towards wrapping up, because we have really passed our time. And like Rajiv said in the beginning, we finished by 6 o'clock. So anyway, I want to thank everybody here, the speakers, the panelists. It was a very good discussion. And to wrap it up, like PCL injury is not as common as ACL, and there are a lot of things in PCL injury which are still not certain, like starting from how you diagnose an acute case, and when you treat, and what are the techniques. But this, I think, was very elaborately discussed here. I hope all the participants, had a better idea than what we started. I thank the speakers, our younger speakers, Sushil and Vijayendra. They were excellent, much more than what I'd expected, even more than what I know. And the esteemed panelists here, who gave their idea, and how we should go around. I better think we should bid farewell, but before that, I would want our scientific chairman to tell us something about, like what is going on, what do you want, how do we proceed further. So Sailas, can you say something? Just, wrap it up.
Hi, everyone. Really nice. I enjoyed this. I learned a lot. I don't do a lot of PCL, and this has been very helpful for me itself, and that's fantastic. Well, I think after the PCL, we should go on to multiligamentous injury. That is this focus on the next time. So we will definitely need, experienced people like Amit and Rajiv and things like that, because I think you all have got fantastic experience, and not only for the juniors, but even for me, it will be a learning curve as I get along. So I think that's what we'd like to do. And thank you very much for participating and putting in so much of effort. Thank you. That's it. I think have a nice evening.
Okay. Thank you. Have a nice evening.
Thank you, everybody.
Bye.
Thank you.
Bye. Thank you.
Okay, bye-bye.